Hi, I'm Jeremy. I run the regenreport.com. I cover the stem cell and regenerative medicine industry. And if you're like me, you're curious and maybe excited about stem cell therapy and regenerative medicine, or maybe you work in the industry, and in your research, you found just nothing but conflicting information on are they safe? Are they effective? Are they a scam? Are they expensive? How do they work? What could they work for? There are so many different types of regenerative therapies and even tons of different types of stem cells out there. What's best for me or what's best for others or a loved one or what have you. And again, just when you start researching, especially patient groups and on the internet, but even the published research, there's a lot of conflicting information out there. And I'm confused, and I think we all have generally the same questions. So I thought, what better way to learn about a a lot of those questions than to hear it from a physician who is using these therapies, who has applied many different types of therapies and can kind of compare them all to each other firsthand from a physician's experience. So I did. I interviewed Dr. Anwar, who runs Chicago Stem Cell Therapy and Pain Management Institute. So he's got 20 years of experience in interventional pain management and anesthesiology. And again, he's used both autologous therapies, so PRP, platelet-rich plasma, and bone marrow concentrate, but also some allogeneic therapies like umbilical-derived, I think like Wharton's jelly, exosomes, these perinatal tissue products. He's done both, and sometimes he combines the two, and he's able to pick which one that he wants to use depending on each case. And he had a lot to say about all of his research and innovation in the field and where it's at, how it's going, where it's going in the future. And it was a great interview. Before we get started, a couple quick things. If you wouldn't mind giving this video a like, maybe a comment, and if you're interested in keeping up to date on, I interview doctors and labs and also keep people updated on trials and new technology coming out in the stem cell field. If you're interested in that sort of thing, you could subscribe to the YouTube channel. Or if you go to the regenreport.com, I do a weekly newsletter that'll go right to your email. I'll send this video and any write-ups and all the other stuff there. And lastly, not medical advice. I'm not a physician or clinician of any kind. So especially before you take on anything like experimental, like stem cell therapy, definitely talk with your doctor. So enjoy the interview with Dr. Anwar.
Yeah, so we've been basically doing a different kind of medicine, which is a future now. It's called a regenerative medicine. Uh, Regenerative medicine is popular all over the world, mostly in Germany, Japan, and Korea, taking the lead on this medicine. And recently, it started getting more popular on the West Coast and the East Coast. And I I'm glad that I started these kind of regenerative medicine therapies now in Chicagoland area and Midwest. Um, we're the first one to put up the center like this and start looking at offering regenerative therapies. In layman terms, people know that they are called stem cell therapies, um, and these therapies uh, are available now here in Chicagoland area. Although there's a lot of research going on, major institutions like Cleveland Clinic or Mayo Hospitals or MIT, they're all doing research and they are starting up their departments of regenerative medicine in every hospital. They're considering starting the departments now. We don't have any fellowship program or any residency program or any uh, medical programs available where people get trained on regenerative medicine. But regenerative medicine has an application in every medical field, and everybody can use regenerative therapies like stem cell therapies. And they're different therapy, different kind of stem cells come from your body or come from the fetus or the placenta of the baby. These cells are available and they are uh, now going through the clinical trials, these products. They're going through FDA regulations. FDA is not as strictly used to be. These products have safety issues before, and now the safety issues are not an issue now. And these products are available to us in our centers here. Uh, these are placental products, and umbilical cord products and amniotic fluid products, they have a tremendous potential to repair and heal the areas wherever we're going to inject. It can be in any part of the body. We can inject those in any specific part of the joint or muscle injuries. We have a lot of sports injuries, which we're treating. A lot of these athletes don't need to go outside the country to Colombia and Panama and other countries now to get the treatment done. It can be treated right here in Midwest, in the Chicagoland area. We have all the products they need. We have the stem cells, we have the plasma, we mix it, and we inject to repair the cartilage, uh, any muscle damage. So a lot of these sports injuries, where the celebrities and all these people are looking into it. So it's just a matter of time that more and more people will be doing those treatments. It's just that these treatment needs to be done under strict guidelines. Uh, we have formulated all our guidelines, and we spend a lot of time putting those guidelines together with the other physicians uh, who are looking into acquiring a regenerative medicine as the future of the medicine. We can repair any part of the body. We can offer these treatments to multiple um, medical conditions like degenerative conditions, neurological conditions, MS, Parkinsonism, dementia, um, and now these products are used for um, osteoarthritis, rheumatoid arthritis, and diabetes, and even for improving heart functions in patients who have heart issues. So it has a tremendous potential to repair any part of the body. IV infusions are the best right now for the whole body for the wellness repair. So I'm just giving you the whole overall view of what is regenerative medicine, why it's important to look into that before consider surgeries. The old traditional medicine of steroid treatment or surgical treatment will be the treatment of past because they are degenerative. They degenerate the areas. We're talking about repairing and regenerating it.
What was that moment? And when was that moment when you were going for previous more symptom-based resolution to curative things, or at least having different tools in your toolbox to regenerate with regenerative medicine? What was one of the moments? Was there a paper that came out of like Korea, in the 90s, and you were like, what is that prolotherapy stuff? That looks like it might be a thing. What was that moment where you're like, I want to look into this?
So it started like 6 or 7 years ago. Uh, what happened is that I was thinking I've been treating like patients for a number of years with steroids, gel injections, surgical approaches, and patients keep coming back and back and back, and a lot of this time the patients say, you know what, I want to go to Germany to get these treatments done. So I started seeing the athletes started going, and I said that what is different here, in the other part of the country they're doing that is not available here. So I think I was searching and googling and all that, and I found that there's in West Coast there's a group of physicians doing, it's called Cell Surgical Network, and
Yeah.
they're doing some adipose tissue and bone marrow uh, to be used for the stem cell. So I went to their conference. I just picked up the conference. I said, I'm going to go and pick up the brain. And that's how it started there 6, 7 years ago. I went there. I met with plastic surgeons and a couple of other surgeons. And they were doing this thing and they're coming out with the research and they're saying, this is what's going on in Korea. So they have these Koreans helping them. And then after that, I started going to some other conferences. Then I have another physician. He has some connections in Germany. So I went there in Germany. I went to a couple of these clinics and then I saw them using stem cells for IVs, and they're using different kind of stimulations machine, and they're looking for the wellness purposes. So, and I started looking at the clinics in Germany. They have like 7 to 8 different conferences on stem cells every year in Germany right now. And they have multiple centers which are offering regenerative therapy. It's a small country, you know, and they are, and their websites, you go into the website, they're way ahead and advanced. I realized that this is the future. Why not, look at the repair? And that was the moment, when I went to this conference that I decided that I want to go into more repairing type of medicine, you know. Only thing is that I was also getting tired of our current healthcare system because we treat and put patients on opiates, put them on pain medication, put them on same injections again and again, and they're not moving forward. And that was the one thing was putting me off. And I don't want to take care of these patients and prescribe them opiates and prescribe. So that was the moment I decided I want to switch to this. But switching means I have to learn, I have to implement few things, I have to put the guidelines, I have to get the right people with me. Unfortunately, this is not covered by the insurance company. I have to come out with a model where it's a self-funded model from the patient, and it has to come through the patient. So that was the moment I decided. And it took a start 5 years ago, and slowly, gradually, I transformed my practice into stem cells. It was painful, but it was something I wanted to do it personally. It was personally for myself that I want to just get into more repair and healing. And I spend more time. It's more like a concierge medicine. I can sit down with a patient for an hour and figure out exactly what he needs. Uh, the insurance companies are not allowing me to spend more than 15 minutes with a patient.
Yeah. Yeah, and it's tough. I mean, I'm not a pain physician like you, but I imagine that for regenerative medicine, that patient population of people in pain, constantly returning, that's probably a really difficult population to deal with. It probably comes with its own just just stuff, as opposed to helping them actually get back to normal and get their lives back together. Because previously, the previous methodologies wasn't always doing that, and it came with a lot of extra dangers. And yeah, I mean, with Germany, and we could talk more about this, but yeah, with especially in regards to PRP and such, that kind of had some breakout moments, especially with like Kobe Bryant. 15 years ago, he got that PRP on his knee, and everybody was like, "What is this athlete doing?" And he returned to the NBA after that. And if you consider that sort of timeline for, especially for allogeneic stem cell therapy, um, that's kind of what we're seeing right now. We're in those early days. We have so many celebrities, Joe Rogan, UFC athletes, all these people coming out on social media saying that. And yeah, it's a very interesting time.
Yeah, I mean, these are very basic therapies. It can be done in anybody's office, but then it needs guidelines and, it needs knowledge. So, and it's a preparation of the patient. They have tons of questions about these therapies. PRP is very simple. It's from your own blood. And then when you start mixing the amniotic fluid or other stem cells like mesenchymal stem cells, or injecting exosomes, you started mixing different products and then make it a potent product to be used for repair. Orthopedic surgeons can do that, but they're not doing it because it's just an insurance model is working with the more surgeries and more revenue for the hospitals. Uh, I think it's time for people to start taking care of their care in their own hands. You have to start reading about it. That before they get into any surgical decision making, they should look at all the other options available. These patients are already treated with insurance providers over the years with surgeries and injections. They have to look out of the box and look at the new medicine. And people who are coming to our door are knowledgeable. They're reading about it and they're thinking about it and they're coming with their own will. And then we are offering them these treatments, and then we're selecting these patients based on their outcome. What are they looking for?
Yeah.
Uh, Fortunately, all these celebrities, even Nadal, he's got some elbow epicondylitis or tennis elbow. He gets PRP, the tennis player. And then there are a lot of celebrities. Even Tiger Woods at one time was getting injections in the knee. Um, so a lot of these people have money, but it's not very expensive treatments. Uh, it's expensive to go out and live and treat there is expensive because they have to do all these treatments in short period of time. In US, we don't have to bombard you with the treatments. We can spread it out, and then we can have a close follow up, see the outcome, go to the next level, go to the next level. Within 3 to 6 months time is a good time for patients to see the response and say, hey, you can see the difference.
Could we go into what you guys offer? So you do both autologous and some perinatal tissue products, and sometimes you mix them. So could you run down what sort of therapies that you offer? So exosomes, amniotic fluid, things like that.
So we have, first of all, the product we have is the autologous product is your own product from the plasma. I used to take autologous stem cells out of the adipose tissue and bone marrow when I started this a few years ago, and then I stopped doing it. And the reason I stopped doing those autologous adipose tissue and bone marrow, because the number of viable cells or healthy cells are not as much. They're only in millions. And I need cells in billions and trillions. And I can get those cells from the placenta or the amniotic or the umbilical cord. So I started looking around. I met with Dr. Duncan Ross, from Camara Lab. He's a PhD scientist, and I met many other physicians and many other people, and I realized that some of these products are in a very high concentration available from the placenta because they harvest it in a standard sterile conditions, and these companies have all taken all the safety measures which are and they are in compliance with the FDA. So FDA has an accessibility to their labs. FDA is already regulating their labs and making sure everything is collected properly. And they freeze these stem cells after the harvest from the placenta, and they store it in a negative 84 degree centigrade temperature. And then they ship it to us, and then we mix it with the patient's plasma, and then we inject it. So plasma is like a medium, it's like a fertilizer. You're using your own plasma as a fertilizer. Why? Because it has all the growth factors, it has proteins, it has got all the good nutrition you need for the repair. Plasma itself is not enough for major repairs. For small little ligament repair, muscle injury, like in sports, it's okay for acute injuries. But if we inject this stem cells into which is coming from the placenta, like exosomes, you know, they use Wharton's jelly now, which has some issues with the safety, but it's going to happen is the Wharton jelly will be available. Some places are available. So all these products which are coming, we mix it with the plasma, and then we can inject into certain joints in the body. And my specialty interventional pain. So I've been treating disc pain or nerve pain or sciatic pain or back pain for many years with steroids. That was my training, was interventional pain. Now I'm injecting plasma and other products right into the area and repairing it and getting, results are amazing results. Patients are getting better results with these products than they were getting with epidural steroid injections or lumbar epidural injections they were getting with steroids all the years. We still, in this country, people are still practicing steroid injections, but steroid does not help more than a few months. And then you gain weight and other issues. So I revolutionized the whole treatment option in the back and said, let's get plasma there. Let's treat with plasma. Let's mix some other products with plasma and repair those areas and get a longer lasting relief and a better quality of pain relief. So, and then we're using these stem cells like exosome and other stem cells. We also mixing an IV, and then we're treating the whole body. We're treating for the wellness purpose. Like if I have a athlete walks in, he said, I have inflammation all over my body, my joints hurts or whatever, I need more strength. It's used for the wellness purpose. Or we have patients walk coming in with arthritis and say I've got multiple joint problems, my knees are hurting or my joints are hurting. I have a autoimmune condition of arthritis or other arthritic conditions. IV infusions are going to help them. We are using it for neurological conditions where we need to repair some of the cells in the brain to work properly, like in MS. And then now early dementia, they're talking about. They're using it in Germany for early dementia and generalized anxiety. So a lot of these medical conditions can improve. People are have generally, you have some kind of lung damage from post-COVID now. A lot of these patients are coming because they have multiple hospitalizations because of the breathing issues they have during COVID, and they never recovered. They are dependent on inhalers or oxygen. They have a limited respiratory ability to do things. And now we're doing the IV infusions of exosomes for them to help them with the breathing issues. We have patients who have we treated for other medical condition, but they came back. They said, "Oh, my heart doctor is very happy. He said your cardiac functions have improved." That the one thing about COVID is the Camera lab had already have an IND for post-COVID patient. Their actually product is going through the trial. Camera lab exosome product is going through the trial with IND trial, and their product we are using it on patients with post-COVID syndromes.
Yep.
So there's a multiple application of these products, and the results are really good. Patients are IV infusion patient are noticing their changes in the color of the nails, changes in the hair. They've also noticed the skin color, skin tone is better, and they're telling us this. They can feel these things, although they're here for joint pain or other pain, and we recommended them these treatments, and they have see. So there's things you can see, but the things you cannot see is it means it's improving every organ of your body. Every cell in your body is getting repaired.
So, and not to put you in the hot seat here, but the counterpoint that the audience will say is that, given that from a traditional standpoint, almost none of these exosome or stem cell therapies have gone through, phase 3 trials, maybe one or two of them. And if we're lucky, they have an IND. There's a couple companies that have an IND for post-COVID. That seems to be pretty common. Some of them are showing some good promise in, small, maybe up to phase 2A or so, little small efficacy trials. Um, what sort of evidence is there for you to apply, let's say, stem cell therapy or exosomes therapy for something like a nerve or orthopedic application?
Uh, there are two things I'm going to say. First is that our current healthcare system, the insurance providers are not working with the research, you know, environment. Although they have a very good ties with the hospitals, they don't want these therapies to come. Why these therapies are available all over the world and is being used? Why in Korea they're treating hearing defect with exosomes and plasma? There's a lines and lines of people sitting outside and they're treating hearing defects with exosome. Why they're not looking at neurological disorders which are treated in Germany with IV infusion therapies? That's one side. This current healthcare system, in this current capital system, allows surgeries which makes more revenue producing model for the hospitals. Why they adopt to a system of healthcare which is early prevention, pick up the problem in early stages, repair it. That's one argument I have. The second thing is that yes, I agree. A lot of people have doubts about okay, because they're not any published data. There's a lot of published data, and if you look at the published data in Germany and Korea and China, There is a lot of published data there, but there is no published data coming in US right now because we are beginning to see it. We are right now, we have 400 physicians. So to some extent, we are partnered and we filed a big lawsuit against FDA on saying that adipose tissue stem cells are okay to be used because they were against adipose tissue. They said you're manipulating adipose tissue. There was a big argument, and then stem cell surgical network, they won the lawsuit, and adipose tissue is being used now. It's been
I
bone
think that
marrow.
overturned.
They can overturn anytime. They can do that, but fat is being used for transfer for many years. Plastic surgeons are using fat for plastic surgeries. Does it have any? Is it different than using adipose tissue? They use the same. They take the fat out. They put the lidocaine. They put all the bicarb. They put all these chemicals. Break the fat, and they put it on your face to facelift. They put it on your butts for a butt lift, and they can use it in any part of the body. How that is different than using adipose tissue for stem cells? It is.
Well,
It's an argument to make, but the thing is that FDA is not a. They're not clinicians. They're not going to decide. I think the problem is that this big pharma is 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 very powerful. I think I don't want to make a comment, but I think the FDA eventually people will use it, these products, and they will see the results and outcome studies will come, but they have to come out with some research studies. They name these things differently. They say, oh, this product is bad, this product is bad, it's got an IND or this, and then it will be a lot of bad names coming, but people will misuse it too. So that's why we have to identify a lot of people are misusing this name of stem cells, and then I'm surprised that a lot of these people they spend a lot of money and they get the stem cell. It was not the right stem cells they received or the right way. So people have to be very careful, picking up the right provider, and they need to have enough knowledge. So that's why the people are unhappy because we get a lot of people here. They're going to chiropractors, and they say this chiropractor told them to get the stem cells. I said,
yeah.
well, how come chiropractor does it? Well, he has a physician who came and injected it. So the question is that what are they injecting? How they're injecting? Does they have an MRI? Do they look at the cartilage? Do they look at whether you are a candidate, yes or no? First, we have to select whether you really need stem cells or not. You have to have a practice of medicine. Not everybody is a candidate. So those are the things. Uh, that's why it's a new specialty. You need a residency program. You need a training program. You need physicians who can sit down and explain that if you considering stem cells, what are you looking at? How are you going to get repaired? So there are a lot of things there. Are you really a candidate? Yes or no?
Mhm. I mean, I agree with a lot of what you just said. With the case with the Cell Surgical Network, I believe they initially won that lawsuit, and then the FDA overturned it. And the problem was twofold, if I remember correctly. One, it was the use of collagenase as an enzyme to break down the fat and get the mesenchymal stem cells out of there. And second off, maybe some sort of contamination, or maybe it was non-homologous use. And there is a difference between a plastic surgeon taking fat out of your belly and making the booty look bigger, as opposed to breaking down the rest of the adipose tissue and using those mesenchymal stem cells to regenerate something like cartilage or ligaments. Those are two pretty big different use cases, but I mean, it doesn't mean that it shouldn't be used. Just a matter of similar to what you just mentioned. It's all so new, and there are definitely inner workings of the FDA and big pharma. Although I try to shy away from that, sometimes I find that these buzzwords to be a little bit inappropriate and can actually shy people away. When in actuality, I think what we need is, and I'm pro stem cell, by the way. I've had 4 treatments myself, and I couldn't walk. I was bedridden. It was extremely scary. I'm a reporter in the industry myself, but in my mind, what we need is actual good evidence showing that it does work. especially to combat some of the bad actors. Not even some of the bad actors. It's mostly, it seems like just nothing but bad actors, or the majority of people doing things in the space tend to be not very good. There are great physicians and great companies in the space too, but they take advantage of the fact of, there is this big problem. It's new. We have issues with the FDA, and we don't know exactly how it works. So I don't know. I mean, in my mind, it's even though I've done several treatments myself and looking at others, I'm still very uncomfortable with the fact that there is not traditional evidence, phase three trials, things like that. In my mind, what we need is to completely change. We need to overhaul the system because the whole the whole getting therapies to the market system is built around very expensive clinical trials, pharmaceuticals, these sort of things. While these cellular products or regenerative medicine is all brand new, so we need to figure something out to change that. Until then, the way it looks is that there's just no evidence, and it's very scary to
I
patients.
no, I agree, and uh, there's not enough information there for the patient to really scale it out. That what kind of treatments they need and what kind of providers they need to go. We have patients who coming from other countries and they have infections, in Mexico and other places.
Yeah,
Uh, so we don't know what kind of product. We in US are going to work with the companies who have, number one, what for the patients should look for is they should, if they're talking to a physician or a provider who's doing stem cells, I think it needs to be an MD number one, MD physician or DO. And
yes,
second is then they should know that they should ask these questions that what the products you're using, what are those labs regulated by? Are they good labs? Are they good products? There's no infection risk, no risk of rejection. And if they are regulated by, I mean, although these products are not approved, we know in US, none of the products is approved by the FDA currently.
yeah,
Uh,
maybe one.
but they're using these products even in burn patients for a long time. You remember that jelly, the amniotic fluid jelly?
Yeah, yeah.
There are a few companies who their product works. They use on
Hmm.
burn patients a lot. They use
Yeah,
graft. So these products are there and they have the certain indications where they're working. They need to ask these questions to a physician. And then they come up with a plan, a short term plan, and say, yeah, okay, I want to try this and I want to see what kind of outcome I have. I have a better quality of life, pain reduction, improvement in health, and then go from there. So these are the questions, patients have to, uh, there's not enough information for the patient. That's the problem, Um, and I think the only way a patient can research and look at the physicians who are doing it. That's what they can do, and there are physicians available in US now. A lot of these celebrities have money; they're going to Germany because they don't trust the system here, and they have the means of doing it. Why are they going there? Because they have studies there, and they have system there, they have clinics there. Uh, I mean, these treatments. I mean, they're going to be using these stem cells for transplant of cornea and other stuff.
oh yeah.
They're going to be start using it for a lot of different reasons. It's just a matter of time.
Yeah, I agree, and we're in just such a strange mess, that the FDA has unfortunately been a big part of why we're here, and that's, to your point, patients are flying to Germany if you're rich, but for your normal person, they're flying to Mexico and they're getting something from some Sophipris regulated lab injected into their spine, and then they land in the hospital with meningitis or something. And what it says to me is that clearly there are people at the end of the road with today's medical system. There's just no answer. TBI, stroke, uh, many orthopedic things, nerve, any lupus, cystic fibrosis, the list goes on and on. There's no answer. So there's clearly people who want to try something that there's maybe a 20 or 30 person trial, but they can't do it here for
There
all
you
these.
go. So these
So you
patients
fly
are
to
coming to
Mexico
us.
to get it done.
Exactly.
Yeah, and it's like
Exactly. These
you put those patients in danger because they're going to do it regardless. They're going to roll the dice, and often it goes not very well. And I find that also very inappropriate for the FDA because at least, especially with these patients that are in massive pain or going to die, at least let them try this thing that shows a little bit of promise with a physician that they trust in a system that they know,
there
not
you
one where
go.
you go to Panama. So, I just it's nuance. It's very difficult. I believe in that. I also believe in holding feet to the flames, and we need more data because the other side of the coin is that there's a profit motive for cash only private practice clinics to say, yes, this can help you, and whether it will or not, patients just, how do we know? So it's tough.
I think that's your closing statement should be these patients are so desperate, they're looking for any help. And they are coming, they beside any kind of studies or papers, they're looking for some value from the outcome it can bring it to them.
Of
The
course.
better quality of life. That's what they're looking for. They're coming with their own intentions and they're looking for at us to provide them some other treatment options. So you're right, you're absolutely right. So we have all sorts of patients coming in. If a patient comes in, he said, you know what, I don't want to go through a knee replacement surgery, you know, because my doctor suggested it. And we looked at it and we said, yeah, you need a knee replacement surgery because it's too late, you're bone and bone,
Yeah,
he will be fine. But if somebody treats the bone on bone patients with stem cells and not get a good results, that's bad. So there's a lot going on. But if some younger person walks in and he say, doctor suggesting me that you may need a knee to knee replacement in 10 years or 15 years because the injections are not working, if it's got a good knee, it's got a good chances of repair. And the traditional medicine, one thing is lacking, which I will really stress, is once the repair is done, then strength training should be started. So in our facility, we have a strength training coach, and we have formulated a plan of strength coaching for that patient after he got treated and he gets some relief. And we look for 3 to 6 months after the treatments are done. We got them into a strength training coach. These cells are not going to fix your problem for rest of your life if you're not going to change your lifestyle in 1 or 2 years. These stem cells will repair you, will give you enough chances for a few years so that you can start exercising, start strengthening your, because it's a human body, it's not that, oh, you fix the stem cell, it means it's fixed for the life. No, there's no quick fixes. A lot of education needs to be done. That needs time. Physicians don't have time. There's not enough information there. I'm telling you, this is this
I
is
know.
this is how it is. Uh, Patients coming in, they said nobody talked to me. Physician spent me 10 minutes. He never talked about this thing what you're talking about. Nobody talked to me about strength training. Nobody talked to me about therapy or home exercise. Yes, doc, I can't. I'm working. I'm so busy. I have a flight to catch. I work here, work there. I don't have time for myself to do strength training. I say, well, I'll do the stem cells for you. I'll fix you for 3 months. Next year, you're going to come back to me. I'm fine with that. You're paying me, but this is the way to go. So I think the strength training program with regenerative medicine, that's what's happening in Scandinavian countries right now. In Sweden and Finland and all those other, they have the amazing healthcare system. They're very focused on rehabilitation with therapy, exercises, those kind of programs. Those kind of programs should get the priority right after the treatment is done to repair. Whether it's surgery or whether it's stem cells or whether any other treatment, strength training program is very important. And I'm a big fan of that. I'm a Ironman. I've done multiple Ironmans.
Oh yeah.
I've treated my knee. I've treated my plantar fasciitis with the stem cells in my plasma on my own. I've injected myself over the years. I'm still training for different things on a daily basis, and I'm very big fan. And I think I have the coach I have here. He helps me out a lot, and I think I have these coaching available for people because I firmly believe that you can change your life after the repair is done by formulating few changes in your life with little strength training program. You need to take care of yourself. If you can't take care of yourself, you can't take care of anyone else. So a lot of these things are, you need to spend time with the patient. You need to show them the outcomes. And these patients are coming regardless of any papers, any kind of studies. The value we're bringing is with the outcomes of the patient, and that's the value we want to bring.
Yeah, that's pretty much right in line with what happened with me. Long story short, I was looking at upper cervical fusion, and instead I went the regenerative route and had 4 treatments. They're all very painful, and after that, I could walk a little bit, but still had a lot of problems. But when I started adding in the strength training on top of that, it was a lot of work and education for myself. But that's when things really started to change, and now I'm able to do a lot more. It's an entirely new way of doing medicine, and patients just don't understand it yet. But that's what we're trying to do here. So speaking on some cellular questions here. So one big, and maybe this is going to get into myth busting territory. One big claim out there is that there's a study done, and it's a very limited study. They only tested maybe 4 products or so. And this is by an autologous corporation. They tested 2 amniotic derived and 3 Wharton's jelly derived products, and they found they had no living cells after they thawed them. And they used that as a broad paintbrush to say there are no living cells in any of these products in the USA, and this is all a big scam. But obviously, the counterpoint to that is here's our third party analysis done at a good laboratory. So, what's your thoughts on that?
Yeah, third party analysis is important, and you're right. There are companies who have gone through these issues. The Warden's jelly, the issue you said about Warden's jelly and the number of cells. I'm not surprised. These kind of quick medicine and these kind of quick businesses, people have done it. They may be selling saline water and they're saying it's, they're making money out of it. So I don't know about, I know these things have happened in the past, and that's why there is no regulations right now that what companies to pay. Who's going to regulate it? AMA is not going to do anything. American Medical Association has never done anything for the physicians. So who's going to take the lead on it? The lead is going to be taken over by the associations like Cell Surgical Network, American Academy of Stem Cell Physicians, World Stem Cell. These companies are going to come with a guideline. They're going to come with the companies, and they're going to say, look at the companies. Like we looked at Chimera Lab, who is going through IND trial. They have a third-party testing.
Yeah,
Third-party testing is done by the FDA and other people. They recommended third-party testing. You need to have a third-party testing. You need to have labs which are regulated on the same principle like you regulate the labs with the pharmaceutical industry where the products are prepared. It has to
CGMP.
be same standard. It needs a lot of money and a lot of time, and they have to go through the same process. So I think physicians right now don't have. I'm taking my time to find the right companies, find the right products, find the right mix. There are no guidelines for us here. That's why I think regenerative medicine, it has to come as a separate specialty. They need to have a board who'd sit down and decide the guidelines, whether okay, adipose tissue is good or Warden's jelly is good. What kind of cells, what kind of cell types you get in Warden's jelly, what kind of cell types you get in adipose tissue, or bone marrow is good or not, and indications, contraindication. We have to formulate those guidelines. There is nothing happening right now. So whatever the studies and or the data we have available, I have to go internationally and look at the data.
Yeah.
You know,
Yeah, it's uncomfortable to have to make clinical decisions based on some paper, in some random country. It stinks.
exactly.
It's the situation.
So exactly. So it's very difficult. When the patient comes to me and he said, "Doc, I'm looking for miracle. I have nothing left. I've tried everything. I've tried all the injection surgeries. Can you do something for me?" And he's willing to take the cost and funding and all that stuff. I say, okay, well, there are a few things I can try. I cannot guarantee, but I may make your life a little bit better. And that's what we do.
Yeah.
And we look into individual, every individual, we look at it differently. They have different needs, you know. That's why this medicine is important, because we can treat multiple things. We have few patients, they reported that their cardiologists are very happy with them, because two of the patients said their ejection fraction is improved. One patient said they took him off the cardiac medications. Oh, this is good to know with IV infusion therapy, but I didn't know that. That's a good
Yes.
outcome. So now another patient walks in. So we have all these small little outcome data available. I think we need to start putting it together. We need to start some IRB study. There are some studies already started right now. So we have to get into IRB studies. We have to get into those. We have to partner with international community and see what kind of studies we can do with them. Uh, let's see. I mean, it's a process of evolution. Um, what will happen? There'll be physicians, you will see more and more physicians coming out with these treatments now. A lot of the growth factors are picking up now. A lot of these surgeons are using growth factors
Mm,
in the
okay.
surgeries,
Mm,
and they're all coming from the derived amniotic fluid growth factors. You know, People have given bad name to amniotic fluid and all that stuff. I mean, if it's a good product, amniotic fluid is used for membrane product. Like for the grafting. This company, what's the name of the company? I used their product in the past. I like it. Uh, they are using the amniotic cell membrane in centimeters, and they put it on the burn patients, on the wound clinics, diabetic wound ulcers. That's a big thing, but it's working.
it is. Yeah, I mean it is a big thing. And it's so funny. Somebody at the FDA just pointed out how the laws are so messed up for that because you can spray on or apply that amniotic fluid to a burn to heal that. But if you use that same product as a barrier for that burn, you can't do that because that changes it from a 361 to 351. One is like homologous, one's non-homologous, and but there's something here. We just don't know what that is, and we won't know until we can allow data to come out and get more data. And also, as dangerous as it may sound, also give sometimes physicians a little bit more flexibility to look at the clinical data and say, no, I know my patient very well. I know what's going on. I've seen enough data, and I think they'd be in a good position to try and get more data from that too. Um, and that scares people, and it scares me too. It's because it's so untraditional to what we're used to. So, but I mean, what else can we do? Whatever we're doing right now is not working.
Yeah, I mean, there's a misuse of the products, misuse of the companies, and a lot of these companies who are really good, they don't have enough money to start the trials and make for big pharma has a lot of money.
Oh yeah,
They can get 100 physicians to start the trials on a certain drug. Uh, they can come out with any drug, and then they say, hey, this drug is. They've done 100 clinical trials on that, but I don't think this country is supporting regenerative medicine. Right now as a new medicine. This is the future. It is the future of medicine, repair and healing through your autologous or non-autologous, whichever way you use it. You should look into these as the major medicine in the future here in this country, and we can take the lead. We're always in the forefront of the research. This country, the only reason this country has the best healthcare in the world, and we are way ahead of Europe and other places, is because of the research and the money we have. If we going to take this money out of the research from the universities, I think they should allow funding on the research of regenerative medicine. NIH should come out with the funding. They should come
agreed.
out. They should come out. They say, okay, well, we have a current healthcare system. We need some research. We need to allocate some portion of the money to regenerative medicine. They need to have a
Yes,
budget. They need to have, okay, what are the guidelines? Who's going to go run the regenerative medicine? Should we have a residency program? Should we have some clinical trials done? They need to do that. They need to have that initiative. I have not seen that happening. And if it happens, all these physicians who have, they will be the first one to jump in. I'm already trying to get IRB studies in my clinic. I have a hard
Mm,
time. I
really?
want to start new studies. I have the access to software where I can start putting data. I'm collecting raw data here, but I need to put that data in a refined. I want to have 50 other physicians collecting data with me, and then we can compile the data and bring out some good information. It needs resources, it needs clinical nurses, it needs money, it needs a lot of stuff. I think it's time now.
Yeah. Yeah, I agree, and that's another important detail is that we can get a lot of data from clinical trials for drugs and such, and those cost a lot of money, but it's worth the money to say Pfizer or Johnson and Johnson because it comes with a nice, 20-year patent, and they can make that money back. But an umbilical product is a little bit more difficult to patent, and so the capital requirements to get those things done that give us that data are just not incentivized. So I think NIH does need to at least investigate it and see what sort of smoke is out there. So um, I've got one or two more questions for you. So
Sure.
there's a couple of studies that, in my mind, are still to be determined, but there's a couple of studies that show IV stem cell therapy is not not appropriate for things outside of the lungs because of pulmonary first pass. So they took it looks like they took mega doses, very high doses of stem cells, put it into rats, and then did some sort of fluorescent staining to figure out where those cells went. And in the two studies that I've seen, if I remember correctly, 97% of them were caught up in the lungs and then were killed off a few days later. But there are some inklings of IV stem cell therapy working, and I've heard the story of cardiac problems healing after IV stem cell therapy too, but it tends to be anecdotal. So, what are your thoughts? Is there any research or any sort of clinical evidence that you could provide that shows maybe it shows something, or do you think that the studies are conclusive?
So, first thing is that the type of patients we're getting, they're very desperate. They're looking for help. So, if you look at patients who have post-COVID issues, uh, they are looking for any kind of help. So, if they're looking at stem cell infusion therapies and if there's no risk involved and they can be beneficial, and if they want to go for that, why not give it to them? Yes, there are no post-COVID studies done. Yes, there are few products going through IND for COVID, post-COVID syndromes, but that's where we are. Now, yeah, there's some research going on. If you look at the Mayo Department of Regenerative Medicine, Mayo Hospital, they're doing a research on cardiac stem cells. And they have a department actually. Um, I have a lot of information. You get a lot of papers they have written. They're doing this research with the Belgium. There's some another research company in Belgium. They have looking into cardiac cells and improvement in cardiac cell functions with the help of stem cells. So there's bits and pieces of information available here and there. The outcome. What I'm saying, there's no condensed data. There's no compiled data available. That's the problem. That's where we are. So that's why as I said earlier, we need to have a we need to have a dedicated research, and for that we need some kind of regulatory guidelines and funding, uh, either through the big pharma funding if they have an interest. I don't think they have an interest right now, and big pharma is not having an interest. So the only interest we have is on the national level. On a national level, will be some kind of grants by NIH or some other grants to start these kind of projects. Otherwise, with that whatever we have, the information or limited information we have and knowledge we have, we're going to use it and apply it, and that's what we're doing.
Yeah, and I mean maybe that'll change soon. And on the IV thing specifically, Yeah, there's studies showing that it really, from a study perspective, it doesn't look good. But there are, like you mentioned, Mayo, but also U of L and University of Miami. I mean, they've each gotten $8 to $10 million grants to study IV stem cell therapy for cardiac issues too. There's something there, but to your point, we really don't know. So yeah, it can be quite dizzying, especially for patients. It's like where am I going to drop this 20 grand? I don't even know if it's going to do anything or not. But if you don't have
Correct,
many
correct.
options, your risk tolerance is going to completely change.
Yeah, I mean, if it can be used, so some people come here, they say we want an IV, we want in the spine also because I have a problem there. I want in my joints. I want everywhere stem cell. And if they want to spend 20 grand or 30 grand and they want to do it, and there's some areas improve, some are not. That's where the medicine is going right now. Is we don't know, we don't have a lot of answers. Uh, with IV, I have some mixed results. I have like patients coming with good outcomes and patients not coming with any outcome. But I also have some of the patients came back to me after a year or after 6 months and say, "Hey, I think I saw the change, but I was not really excited." So it's like you have to work with the patient. You have to collect the data. We every patient we see, we do this IV treatments. We follow with them 3 months, 6 months, like that. I'm gonna keep following unless patient drops me, or I'm gonna find out, hey, what happened? What was the reason? Was it too expensive? Was it not helping you? Or you got to collect the data all the way, and that's what I'm working on right now. I'm going to collect the data as much as possible. And we have like a patient walked in with a tinnitus and hearing defect. In fact, this patient is a friend of mine. He's an anesthesiologist, and he said, "Doc, can you inject stem cell in my tympanic membrane into my ear?" I said, "Why you want to do that?" He said, "Well, they're doing it in Korea, and I can't go to Korea. Can you do that?" I said, "I'm not an ENT guy, because ENT people do is they go to a tympanic membrane, they inject steroids, at least three to six times steroids." So I looked at the data. I said, "Hey, Koreans are doing it. I'll do it one time." I did it one time. His tinnitus is gone. He used to get so. Hey, doing one patient tinnitus is gone is not a study,
No.
but this is what I did just based because he wants it. And then he came back from the second ear because he's got deafness in that ear. His deafness improved, so they're using it for the deafness now. So a lot of these things which we are doing, we're being case by case basis with the patient's consent and patient willingness to go through the treatment. You know, and I think the only thing which is going to give a bad name to the stem cell therapies are the people who are going to sell these to the normal people and give them the bad medicine and do not work with them. So a lot of these people who have the you have a bad taste in their mouth, and that's why they're saying, "Hey, it did not help me. It did not help me." Is the reason is we went to this one place, not even a physician there. We don't know who's sitting there. Somebody injected something, and they're out of the window and never had a follow-up call, and nothing has been done. Those are the patients who have no idea what's going on.
Yeah.
So we want an informed patient, a knowledgeable patient, and somebody who can sit down with them and go through the goals, what they're looking for. It's a different medicine. It needs a different CPT code. It needs a different. The whole medicine has to change. It needs to have a program uh, where you can talk to the patient and explain all the answers they have and the questions they need. There's a not lot of investigations you need. You're not a lot of lab testing you need. You know, you don't need to test it for. Yeah, you can look at the diagnostics and all that stuff, but it's all about what patient's telling you. You know, clinical exam and all. It's a very different medicine. I mean, if I have to put up a regenerative medicine program, I can work with other physicians. We can put up the whole regenerative medicine program. But we have to come out with the guidelines, what to do, what not to do. Who came out with the guideline to do 3 steroid injections or 6 steroid injections? It came out with all the papers over the years. You say, it works 2 months, 3 months. Now stem cells are working with back injection for 6 months to a year. I have patients coming every year. We need to put those guidelines now. It's a better product than before. It's better than steroids, better than this, better than this.
Yeah. And I think until that gets established, since we're relying so heavily on anecdotes, until we figure out what to do, it's kind of a danger zone. And my biggest fear for other patients is that, that right there is a breeding ground for bad actors, and that happens all the time. So it's quite scary. The inaction is causing that.
It is quite serious. So that's why when we have a patient comes in, we are very upfront with them. We tell them that this is not FDA approved. It's investigational, experimental. We give them all the guidelines. We give them consents. Make sure, because if tomorrow something happened to this patient, they're going to come to me. I will say I documented everything what patient was looking for.
Yeah.
You know, if the patient is coming with rheumatoid arthritis and or MS and he say I tried every medication did not work and giving me side effects, you need to have a physician involved who can say the patient is not happy with the current healthcare and he's looking for alternative and he's looking for here and he came with their own will and there are risks associated with these stem cells too. There's these risks, you should please make sure you put those risks there. Put a proper consent, put a proper documentation. Make sure you save yourself. If tomorrow something happens to this patient, if he comes back, he does not make a bogus claim on you because you have all the documentation. And that's where these patients, these other healthcare providers who are doing those bad medicine, they're gonna get into trouble because if something goes wrong, there's no documentation what you did. And please look at the companies where you're buying the products, are proper companies, work with them, look at the labs, talk to them, find out the right, talk to the other physicians who are into the same practice and find out if you can get some information on that. I think we have to practice a good medicine. That's the main thing. Uh, the only thing which protect you from the law is practicing good medicine with good intention and may keeps the patient happy. That's what it is.
Yeah. Yeah, and all those things. I mean, being very upfront about, hey, there are some variables that we just don't have a powerful enough microscope to even understand, let alone what happens when we put this inside of you. So, and it may not work. It's going to be expensive. I think that's what hopefully most providers are doing. And in some states where they're a little more flexible, like Utah, that's part of the law. You have to have like a sign up front. They have to sign a specific consent form and all these things. And you should be doing that regardless, because that we just don't know. We just don't know. It may be something we really don't know. It might be risky. So, yeah. And final question for you. So, actually, two quick ones. For your equipment in the clinic, especially for orthopedic stuff, you have ultrasound, C-arm, that sort of stuff. What sort of imaging equipment do you have?
So we have an operating room which is Joint Commission accredited with the proper guidelines how to run the C-arm in an office-based surgery. So
Mhm.
we have a C-arm and which is a GEOEC C-arm 9800 C-arm. And then we have a full operating room services available with anesthesiologist, an X-ray tech, and a circulating nurse and recovery room. We have a recovery room with 3 beds. So a proper surgical suite uh, and is accredited by Joint Commission. Same reason, safety, infection control, patient safety, employee safety, everybody's safety. So you need all this stuff. So we have that accredited and interventional pain management physicians wants to join, get into regenerative medicine. They'll do the same treatment, same injections in the back, but now they're using a different product. So that product safety, the freezing of the product, thawing of the product, getting the PRP and mixing it together, that's the only thing which is going to change. So they can do it. And they can collect the data and they can start collecting, and I started comparing my own data, what I'm collecting from the patients I'm treating with stem cells as compared to patients I'm treating with steroids. They're getting better results. They're getting longer results. They're getting better quality of life, better quality of pain relief, longer pain relief. So close the door, please.
Okay.
So I think that's what it is. That you have to have the right equipment, and you need to have an accredited center, not a big surgery center like an office-based surgery center, but get the accredited guidelines there. And
Well,
that's also a safety thing. If tomorrow you don't want to get into trouble that you're doing something against, the guidelines. You have a more proper accredited that's a good standing for you. It's
yeah,
like it's like that you're certified and you're not taking any chances. You're not doing something in the back of your garage or right in your small, exam room. You're doing those procedures with a little. No, you need to have a proper people, proper resources, and then you need to put all this stuff together. It's expensive and it needs implementation, but do it properly.
yeah. Anything to mitigate, there's already risk here, so it needs to be mitigated even
You're
further. So
risking, yeah, litigating, and the patient safety, and the patient also needs to feel that he's coming to the physician who's a surgeon, and he understands the risk. You're putting needles in somebody's back in the epidural space. If there's a damage happen or something happens, or uh, you can say, we everything is done according to the guidelines.
yeah,
So
absolutely.
those are the things.
And my last question couples on that. So you mentioned comparing the data. I assume you have like a patient registry that you use?
So right now the data is we are collecting is all the notes I'm compiling right now. I use a eClinical systems, and I am actually looking into a software program where I can come out with, because I'm doing so many different things, and I have to start categorizing the disease conditions I'm treating, some medical conditions, plus different joints I'm treating and different types of spine care I'm doing. I need to start looking into how many injections I've done. So we have a data in Excel sheet where we're saying this, and then we started collecting the outcome to whatever the patients have outcome. So I'm writing that outcome of the patient into my notes and then started collecting that into the Excel sheet. But it's a raw data. It's not a very defined data. Let's say I have a patient came with a multiple sclerosis or autism. I need to ask these 20 questions to say what are the areas of improvement. I'm looking at, okay, patient say these 4 areas are improved. Okay, these are improved areas. Other 10 areas, we don't know. So we need to have a proper data collection. What are the areas? What kind of product? What concentration? What technique? Everything needs to be. So I'm just collecting whatever data I have. Um, but I think I don't have a design software or anything else. We did speak with someone who can give us a software we can start formulating our stuff. Uh, I want to work with other physicians who are doing the same thing, but unfortunately, a lot of interventional pain management physicians are not doing it.
Mhm. Yeah, there are a couple, I mean, you know better than I do, but there are a couple third-party software systems like data, biologics, I think is one big one, a couple others that will help you with that data. And I think that would be a really good, again, without much published traditional evidence, patients are wondering like, is this going to work? And having any sort of evidence or documented data would ease a lot of that, I think, and be helpful for the industry as a whole. So I think it's a good idea. Yeah. Cool. Well, those are all the questions. Is there anything else you want to touch on, Dr. Anwar?
Well, you're very knowledgeable. How did you get into this debates on regenerative medicine? I mean, I know you treated yourself, but I mean, how are you doing it? You want doing like podcast, or you working on this to have more knowledge, or?
Um, I had the injury, and I'd never heard of regenerative medicine years ago. Um, and I just had to learn what all this was on my own. And I started writing about what I'm learning along the way and finding out just how wacky the industry was. And I've got a stack of textbooks next to me on stem cells and biology and such, and just started writing about it and covering it. And found that nobody was like talking about this from a neutral perspective, and that was harming the industry. So I just started doing it. People started liking it, and yeah, kind of just still going. I got more textbook to read today, and just learning and going, and hopefully it helps the industry.